Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arora, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 416 of our pharmacotherapy series, which majors in lower gastrointestinal disorders. The next clinical case reads: LSK is a 38-year-old woman who has a long history of abdominal pain and episodic diarrhea. LSK works as a sales representative for a major software vendor and is called on periodically to make formal presentations. She finds that just before these presentations she experiences attacks of abdominal pain and diarrhea. Her past medical history is significant for fibromyalgia, which manifests as chronic tiredness and fatigue. She has no other medical problems and takes no medications. She has no known drug allergies. She does not drink, smoke, or use illicit drugs. She has undergone an extensive workup, including colonoscopy, upper gastrointestinal endoscopy with small bowel follow-through, computed tomography, abdominal scans, serum electrolytes, thyroid function tests, and stool studies. These procedures and tests were negative, and LSK's gastroenterologist has diagnosed her with irritable bowel syndrome. LSK currently has 1 to 2 loose stools daily. They are not greasy appearing or foul smelling. She has bouts of abdominal pain, with a severity of 7 on a 1 to 10 pain scale, with or without diarrhea several times daily. She describes the pain as stabbing and cramping. She has not noted any temporal relationship to meals or that certain foods exacerbate her condition. So my question to you reads: what pharmacologic options are available for LSK's abdominal pain? What adverse effects are associated with these medications? Drugs that possess smooth muscle relaxation properties, usually by anticholinergic pathways, have long been used to treat irritable bowel syndrome. In the United States, the two most commonly prescribed antispasmodics are hyoscyamine and dicyclamine, both of which possess significant anticholinergic properties. Clinical trials that have examined the use of these agents in irritable bowel syndrome have been plagued by small numbers and methodological problems, and recently several meta-analyses have been conducted to provide insight in this area. In general, these systematic reviews have found that, as a class, smooth muscle relaxants were superior to placebo in improving abdominal pain, although they are less effective at treating other irritable bowel syndrome symptoms. Unfortunately, there seems to be significant heterogeneity when looking at the efficacy of single agents in this class. Additionally, many agents studied in clinical trials are not available in the United States. Current treatment guidelines list antispasmodics as options for pain or bloating associated with irritable bowel syndrome. if prescribed. An as-needed strategy of use has been advocated by some experts as opposed to continuous dosing owing to anticholinergic adverse effects. Peppermint oil capsules also have smooth muscle relaxation properties and have been shown to be beneficial in irritable bowel syndrome-related pain and cramping. Next we will look at antidepressants. Current treatment guidelines recommend the use of either tricyclic antidepressants or selective serotonin reuptake inhibitors, abbreviated as SSRIs, for patients with severe or continuous abdominal pain. The analgesic effects of these agents are well known, and it is believed that these agents may work by a similar mechanism in irritable bowel syndrome-associated pain and bloating as well as global well-being. One recent meta-analysis examined the class as a whole in irritable bowel syndrome patients and found low-dose tricyclic antidepressants significantly improved pain, bloating, and irritable bowel syndrome symptoms compared with placebo. A dose-response relationship was not noted, and low doses of tricyclic antidepressants, e.g., amitriptyline 10 to 25 mg at bedtime, are often effective in relieving abdominal pain and diarrhea. A 3-month trial at a target dose of a drug, e.g., amitriptyline 50 mg, should be attempted before therapeutic failure is confirmed. Secondary amine tricyclic antidepressants, nortriptyline, desipramine, are better tolerated by many patients than tertiary amines, amitriptyline, imipramine, owing to decreased anticholinergic adverse effects such as sedation, dry mouth and eyes, urinary retention, and weight gain. Selective serotonin reuptake inhibitor use is more controversial in irritable bowel syndrome patients as conclusive evidence of efficacy is lacking. Still, practice guidelines note that these agents are also reasonable agents to consider in patients with pain or bloating associated with irritable bowel syndrome. Information on other antidepressants for irritable bowel syndrome symptoms is limited. A recent pilot study suggested that duloxetine may improve pain and diarrhea in irritable bowel syndrome patients, but more data are needed before this drug can be recommended. Nortriptyline 10 mg orally at bedtime should be initiated with titration to symptom relief and lack of adverse effects. 2 weeks after LSK starts nortriptyline 25 mg at bedtime, she reports significant relief from both her abdominal pain and fatigue. She reports that she is sleeping better, and she now rates her pain as a 2 on a 1 to 10 scale. Her diarrhea has improved somewhat. However, she still suffers from a diarrhea attack before each presentation. My question to you reads: what other treatments are available for irritable bowel syndrome with diarrhea? What are the risks and benefits of these treatments? Let's look at standard antidiarrheals. Small bowel and colonic transit is accelerated in patients with irritable bowel syndrome with diarrhea. Thus, drugs that slow this process should be effective in relieving diarrhea. Loperamide, an opioid agonist that penetrates poorly into the central nervous system, is the preferred agent for irritable bowel syndrome with diarrhea. Meta-analyses have found loperamide to be an effective agent for improving diarrhea and, in some cases, improving patients' global well-being. As with the antispasmodics, as-needed treatment is preferred to scheduled dosing, e.g., 2 to 4 mg orally up to 4 times daily as needed. Prophylactic dosing before a stressful situation or an event during which bathroom access is limited is particularly effective. Diphenazylate with atropine is generally considered a second-line agent because of its increased risk of anticholinergic adverse effects. Finally, cholestyramine is occasionally used in refractory cases of irritable bowel syndrome with diarrhea, especially when bile acid malabsorption is suspected or confirmed. This agent is often poorly tolerated as a result of palatability problems. Cholestyramine also has a significant number of drug interactions of which the clinician must be aware. We will now look at alozatron. Alozatron is a highly potent 5-HT3 receptor antagonist that slows colonic transit time, increases intraluminal sodium absorption, and decreases small intestinal secretions. Constipation is the most frequently reported adverse effect in clinical studies, approximately 30% of alozatron patients, with approximately 10% of patients withdrawing from studies for this reason. Post-marketing reports of severe constipation with cases of bowel obstructions and ischemic colitis were reported. Bowel perforation and, rarely, death were also reported with alozatron use, and the drug was voluntarily withdrawn from the market in November 2000. After extensive lobbying by several patient groups, alozatron was reintroduced to the U.S. market in June 2002, with restricted conditions for use. Prescribers must be registered with the drug manufacturer, and patients must sign a patient-physician agreement and be provided with a written medication guide. The starting dose and regimen for alozatron is 0.5 mg twice daily for 1 month. If, after 4 weeks, this is well tolerated but does not adequately control irritable bowel syndrome symptoms, then the dosage can be increased to 1 mg twice daily. It is imperative that patients not start alozatron if they have a history of problems with constipation, bowel obstruction or ischemic colitis, inflammatory bowel disease, or a thromboembolic disorder. Patients must immediately discontinue alozatron if they become constipated or have symptoms of ischemic colitis, such as new or worsening abdominal pain, bloody diarrhea, or blood in the stool. A recent review of the mandatory post-marketing surveillance system designed to monitor the safety of the drug found an overall low rate of ischemic colitis. And now we will look at newer agents for irritable bowel syndrome. In May 2015, the FDA approved 2 new drugs, rifaximin, marketed as Cefaxin, and alushadalin, marketed as Vybertzi, to treat irritable bowel syndrome with diarrhea. Rifaximin was previously approved for travelers' diarrhea. Because some evidence exists concerning a possible association of bacterial GI infection and irritable bowel syndrome symptoms, this has prompted some investigators to postulate that small bowel flora overgrowth may contribute to irritable bowel syndrome symptoms. The non-absorbable antibiotic rifaximin had been shown in 2 small studies to improve global symptoms in irritable bowel syndrome for up to 10 weeks. More recently, a report of 2 randomized, double-blind, placebo-controlled trials of rifaximin in irritable bowel syndrome, without constipation, was published. In this trial, a 14-day course of rifaximin 550 mg thrice daily was found to significantly improve relief of global irritable bowel syndrome symptoms during the first 4 weeks after treatment compared with placebo. The magnitude of improvement was small, but was considered clinically relevant. Rifaximin is approved for a dosage of 550 mg thrice daily for 14 days for irritable bowel syndrome with diarrhea. The patient can be treated 2 times with the same regimen if there is recurrence. The most common side effects in patients treated with rifaximin for irritable bowel syndrome with diarrhea include nausea and an increase in alanine aminotransferase, abbreviated as ALT. Caution should be used when using rifaximin in patients with severe liver impairment. Eloxadilane is a minimally absorbed micro-opioid receptor agonist and delta-opioid receptor antagonist. Studies have shown that when there is simultaneous micro-opioid receptor agonism and delta-opioid receptor antagonism, patients will experience decreased abdominal pain and diarrhea. The dosage approved for the treatment of irritable bowel syndrome with diarrhea is 100 mg twice daily taken with food, but the dose is reduced to 75 mg twice daily in patients who are unable to tolerate 100 mg twice daily, have no gallbladder, have mild to moderate liver impairment, or are on organic anion transporting polypeptides, abbreviated as OATP1B1, inhibitors. Patients treated with eloxadilane had better clinical response in Phase 2 trials with decreased abdominal pain and increased stool consistency without significant risk of constipation. The most common side effects in patients treated with eloxadilane include constipation, nausea, and abdominal pain. The most serious known risk associated with eloxadilane is the risk of sphincter of Oddi spasm, which can result in pancreatitis. Eloxadilane should not be used in patients with a history of bile duct obstruction, pancreatitis, severe liver impairment, or severe constipation, and in patients who drink more than 3 alcoholic beverages daily. Patients should be counseled to avoid elozitron or loperamide in combination with eloxadilane on a chronic basis, although it can be used on an acute as needed basis. If signs of constipation occur, the patient must be advised to discontinue loperamide immediately. They must discontinue eloxadilane if they experience constipation for more than 4 days. Patients should also be advised to avoid concomitant use of anticholinergics and other opioids with eloxadilane to avoid constipation. They should be reminded that eloxadilane has a potential for drug abuse. In LSK's case, initiation of loperamide 2 mg as needed before a stressful situation would be a cost-effective approach to her symptoms. Should her symptoms worsen or her current regimen lose effectiveness, eloxadilane 100 mg twice daily with food is an alternative, while a course of rifaximin 550 mg thrice daily for 14 days would be considered an alternative strategy if she fails eloxadilane. The patient should be advised not to combine these therapies for chronic treatment and discontinue eloxadilane if she experiences constipation for 4 days. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 417.